guidelines and evidence-based in treating community-acquired pneumonia. One of also a hot topic apart from the COVID infection. So the floor's yours, Dr. Mohammed.
Thank you, dear chairperson. Good evening, everybody. Bismillahirrahmanirrahim. Let me thank the organizers for giving me this opportunity, especially my friend Dr. Imaduddin, Chair of Infectious Disease in ETS. So it's an algorithm of treatment and diagnostic part. To be frank, because it's the most accepted algorithm is from Infectious Disease Society of America, even though we have a lot of algorithms. Next slide, please. So before going through the guideline proper, algorithm proper, I just want to ask you, is medicine a pure science? Like chemistry or physics, medicine is never pure science. It actually applies some parts of pure science. Even if you use validated tools to assess medicine, the result may not be similar in two different patients. So the result may be different. 1 + 1 may not be 2 in medicine. So that is why JCA was telling clinical practice guideline is closing the gap between theory to practice. So what we are achieving in a patient is different from a different patient in a different scenario. So algorithm should be finite and with well-defined outputs, as well as it should be beyond boundaries of the countries and beyond language barrier. When you select all these things, we will come to American Thoracic Society or Infectious Disease Society America guidelines. With IDSA guideline, if you go through this paper, all of us read IDSA guideline. When you moderate recommendation or higher recommendation, then evidence will be low quality of evidence. As you see each recommendation, you can see low quality of evidence, or some of the things moderate quality of evidence. But most of the things is low quality, and some of them are very low quality evidence. So with a lot of advances in diagnostics, still that is the thing. Only some advance we made. Community pneumonia is not only an acute disease; it can have a chronic impact on a patient. So that consensus we could achieve. Yes. And even after, okay, we accept the guideline, then we implement. The implementation of guideline is very low. So there are a lot of barriers when we implement guideline in different nationalities or different places in the world. With this background, I just want to examine different questions raised during preparation of IDSA guidelines. In adult community pneumonia, should gram stain culture to obtain in every patient? No. It is not recommended to get gram stain culture in every patient because the yield is so low. And even if there is yield, 25% it was like viral, it was coming, only 8% to 9% can get bacterial culture. So, but they recommended severe pneumonia, you can go for a culture. There is an identification of MRSA or Pseudomonas consistently, you go for a culture. Previously infected with MRSA or Pseudomonas, go for a culture. And the patient was hospitalized within 90 days in a care facility or in a hospital, we go for culture. The same applies to the blood culture as well. The same, like severe case, not every case we are supposed to go for blood culture. In severe cases, when you suspect Pseudomonas or MRSA, or when there is a within 90 days of hospitalization, we go for culture. And legionella antigen, that when you legionella, by you diagnose result, the treatment, you have to start the treatment because it takes time. So unless it is an outbreak, we don't go for a legionella testing routinely in a patient. Legionella. And it's a conditional recommendation. As you mentioned, you can see the evidence, even with this IDSA guidelines, a coming session, the evidence is low quality evidence. Here you can see strong recommendation, moderate quality of evidence to check for influenza antigen by molecular assay. In suspected cases, it has a moderate evidence and high quality recommendation. Then PCT, go for PCT and start treatment. No, we don't wait for procalcitonin to start treatment. Based on X-ray diagnosis of pneumonia, we start according to our guidelines because the supposed to be guideline for each country different. For procalcitonin can be used guidance. As you see here, when procalcitonin jumps above 10%, at least for prognosis, the mortality is more than 20%. And then comes CRP and procalcitonin. CRP cannot be used as a diagnostic marker because CRP can be raised in many situations. And procalcitonin can differentiate between viral and bacterial, supposed to be. But in Cabinet's trial, what happened is that mycoplasma pneumonia, it was not catching because it was again low value. But anyway, antibiotic stewardship pre-CRP and procalcitonin is useful. This is the prognosis of the case because we can step down the patient. And this slide is dedicated to Dr. Basam Mahabub. We cannot miss artificial intelligence anymore in our life. Another 10 years, if we are not going to that. So, with umpteen number of articles on the system, if you put, this is a AI-based algorithm based on procalcitonin. The cutoff is 0.25. Based on procalcitonin, how you are going to manage the patient. So clinical judgment alone or clinical judgment with a validated tool like CURB 65 or pneumonia severity index, which is useful. Definitely to decide on the site of care as well as to decide on the progress of the patient, CURB 65 or PSA, pneumonia severity index helps. But here there is good evidence that PSI is more useful than CURB 65, obviously, because PSI has all these parameters from age to comorbidities to physical examination findings, laboratory imaging. Everything is included in pneumonia severity index. So this has more value compared to CURB 65. So should a clinical prediction for clinical judgment alone can be used. Actually, we recommend direct admission to ICU. It's basically a subjective decision of a physician with his experience as well as the parameters in that particular place. So it has a strong recommendation, but evidence is again low quality of evidence. And vasopressors or mechanical interest support we suggest because when the COVID comes, we had to treat these patients everywhere in the hospital, not only in the ICU. So it's basically a decision by the treating physician rather than applying the severity index and all for admission. Then comes the actual antibiotic guideline. So without comorbidities, you can use oxycycline, amoxicillin, or macrolide. Again, the macrolide will come back later. Why in some cases, some places we cannot do it alone. And with comorbidities, we are going to use beta-lactam plus macrolide or respiratory fluoroquinolone alone. So when you see that is what I told you, like different places, different guidelines, and the notion of difference between these UK guidelines and North American guidelines in some aspects. Therapy of macrolide, especially azithromycin, the problem is that in some places, DRSP, drug resistance to pneumococcus, may be about 30%. So any place above 20%, we cannot depend on an azithromycin alone medicine for a non-comorbid patient for treatment of pneumonia. But in severe cases, we don't wait for that. We collect culture, we get a nasal swab. Afterwards, we go for de-escalation if it is negative. So, but there is a need for new antibiotics like omadacycline or lefamulin. And these type of antibiotics are on the way, and some new cephalosporins are also on the way. So anaerobic coverage, whether we have to add anaerobic coverage routinely. Anaerobic coverage routinely is not recommended because only when you suspect emphysema or lung abscess, according to new guidelines, is recommended. In a normal case of anaerobes, because most of the anaerobes 24 to 48 hours gastric contents, and it resolves by itself. There's no need for a special antibiotic for that. In the incubation setting, should adults with community pneumonia risk factors for MRSA or Pseudomonas be treated with extended spectrum antibiotic therapy instead of standard CFTR? Yes, of course. In a setting, we have to think of adding vancomycin, which is 15 milligram per kg per dose twice daily, or we give teicoplanin or linezolid. And any of these anti-Pseudomonas agents like piperacillin, tazobactam, cefepime, ceftazidime, aztreonam, meropenem, depending on the choice in your pharmacy, you can use these things. So, when the patient is requiring hospitalization, based on this data, this algorithm can be used. But again, when you're treating these patients, you have to consider known before escalating or de-escalating treatment. So, by guideline, the new guideline, we actually abandoned the term healthcare-associated pneumonia because that was very much misleading. That antibiotic usage was giving like very high usage of antibiotics happening because we are just everybody we are putting in the same box. But some patients have a risk of Pseudomonas, some patient or MRSA, some patient doesn't have. So no need to treat all of them with the Pseudomonas and MRSA coverage. So that is why this healthcare-associated pneumonia category was abandoned in the new guideline. So instead, we go through this algorithm for getting into a conclusion that whether this patient has a risk of MRSA or Pseudomonas. So another question this time, because 2007 this question was not asked, whether the patient needs steroids for treatment. Because this was a big question, there was a lot of debate happened. In between these 20 years, there are 3-4 papers came. There was a big survival advantage with using IV steroids in pneumonia. So finally, they concluded not to use IV steroids, and the same surviving sepsis guideline. When there is a chance of sepsis, you use sepsis dose of steroids rather than left and right giving steroids for every patient, because they were afraid that the physicians will use steroids for every case, and that will create trouble, especially hyperglycemia. So these were the papers we examined. Then they finally strongly recommend that clinicians wait for the results of several studies. Maybe, I don't know, next guideline comes, they may put steroids as one of the treatment, because there are some patient papers which are very much convincing to use steroids and a lot of survival advantage. And now we know that with after COVID-19, we were using steroids and nothing happens. And we actually, for move 50 years before, this was Surgeon General warning, you go to the bed and wait until you're well for influenza. From that, now we have different agents used for influenza, including oseltamivir. So recommendation is that there is a strong recommendation when you suspect influenza, give oseltamivir. Earlier we were telling that within 2 to 3 days. Now, anytime you detect influenza, you give them oseltamivir. And it's a strong recommendation. Even outpatient, there's a conditional recommendation to give oseltamivir. And another question is that when you have influenza and pneumonia, whether to give antibiotic. Again, the answer, it's actually a strong recommendation, even though evidence was low quality, the strong recommendation from the body was strong that you give antibiotic in the to begin with, and the patient stabilize, then you consider stopping the antibiotic in cases combined with influenza and bacterial pneumonia. Then the duration of illness, this was in the previous guideline also. So stability comes, heart rate, respiratory rate, blood pressure, oxygen saturation, temperature, everything is good. You don't have to give the treatment for 10 to 14 days. And we are all responsible, or the government was mentioning in COVID-19, we are all responsible board. Like, keep calm and prescribe antibiotic accordingly. So how to de-escalate treatment oral, resolution or absence of sepsis or hypotension, FFP for the last 24 to 48 hours. The source of infection is controlled, and patient can take oral intake, and patient can receive and feed, and also make sure that there is somebody at home to support him, or you make sure every day you call the patient and make sure that, because last week I had a patient, he went home and he didn't take a diuretic and he came back with a severe pulmonary. So such thing can happen. We have to make sure the patient is taking medicine properly. So follow-up just imaging, here we all do. Now, still our insurance is paying that, but after some time, insurance may come up with why you are doing multiple X-rays in pneumonia. Guideline now. These two big papers, one is in the BTS drugs, it was published, one is in Canadian. So both of them, out of 57 patients which developed cancer, only one was below 50 years. 56 was above 50 years and they were smokers. So unnecessarily, in a young person, we don't have to repeat an X-ray to see whether pneumonia is clear or not. I don't know how much practical is in our situation. Unresolved pneumonia, what we do by guideline, this is an algorithm, and we all know that we ask for complication, alternate diagnosis, and therapy, including bronchoscopy. So there is a period of definition, like when we consider patients having unresolved pneumonia. So then, I told you earlier that now pneumonia is not considered as an acute event alone, especially elderly. And the pneumonia period, patient can have multiple comorbidities, can develop major cardiovascular events. This has to be kept in mind, that when the patient is already on lipid-lowering drugs, we have to continue that, don't stop it. But whether the lipid-lowering drug is going to immunomodulate the patient and give an advantage on ischemic disease, that has to be proven. So until that time, it's not a guideline, but we have to consider this fact. So these are the major difference between 2007 guideline ATS and 2019. There are a lot of difference. As I mentioned earlier, healthcare-associated pneumonia term is abandoned, and cultures were not mentioned in the previous. Now there is a specific guideline for where to do cultures, blood culture and sputum cultures. Procarcinoma is not discussed. X-rays were not discussed before. And antibiotic, actually, the cefuroxime is removed now. Instead of that, there is a new antibiotic, ceftaroline IV was added. And cefuroxime is not there. And anti-pseudomonal agents, as I mentioned, specific criteria is there for Adicat. Corticosteroid is discussed in this one. Earlier was not discussed. And influenza patient antibiotics. A lot of new topics were discussed in this one. And I am sure next this one there will be a lot more they will discuss, because we have now so much knowledge with the COVID-19 when we are treating. So this all will translate into even communicated pneumonia treatment in that case. So before I am going to conclude my lecture, this was a good paper regarding controversies and topics in community pneumonia. In our widely available biomarkers for diagnosis, prognosis, and stewardship strategies in community pneumonia, but mainly prognosis and antibiotic stewardship, it is good. New biomarkers are there on the pipeline, and this is more important than actually antibiotic. And macrolide usage in combination therapy with beta-lactam should be standard of care in patients with severe CTAP. Community pneumonia, as Dr. Amal was telling, that there are issues with the quinolones, and it's not a very harmless drug, because quinolones have its own side effects. QT prolongation, tendinitis, and even CNS side effects are not very rare. And knowledge of local susceptibility pattern in streptococcus, that is drug-resistant pneumococcus, is a very important concern. And we all have to have our own hospital data. And corticosteroids should not be routinely used until we conclude on that topic. And major adverse cardiac events have to be who is admitted, especially elderly people, pneumonia. Pneumonia is no more considered in our therapy. This is only the dosage table. All of you can refer in the system. And whatever I talk until now. Thank you so much.
Thank you very much, Dr. Harith, for this an overview for the new evidence in treating community acquired pneumonia. The floor is open for this question. Dr. Hussein? There is spots here for the mic. Or this might be easier. Please.
Hello. Yes. Dr. Mohammed, thank you. Very nice review and summary. I just want to ask or comment or point you mentioned, and I think we pulmonologists or the internal medicine doctor, all of us not doing good, is the aspiration pneumonia. You mentioned clearly there is no recommendation, do not empirically start anaerobic coverage for aspiration. I think it's not happening. Every single patient, every single hospital, anybody who has quote unquote aspiration, start tazocine, start empirical anaerobic coverage. I think we should change this. The guideline is there. We'll just read them in general. I'm saying not you, me, all of us, but we are not following. Maybe you can ask the question, the audience, who is in the hospital today not covering?
True. Yeah. This question is for general. Who is not using anaerobic coverage? Aspiration. Suspected aspiration.
Everybody is using. So we have to change. This is part of stewardship.
True.
As a community of the respirologists, pulmonologists, that we are at the hospital, if you are consultant, we have to tell the team, don't worry. The recommendation says don't use kada. You are following recommendation. You will not be sued. Don't worry. Nobody will complain about you. You are following the guideline. On contrary, if the patient develops multi-drug resistant and the infection and the family complain to expert, you give your patient something not recommended. That's why the patient develops multi-resistant infection.
True, it's a very valid point, and we are seeing more and more multi-resistant pathogens these days, and it's very, very difficult to eradicate them. My friend Dr. Sahir will agree.
There is a question, please.
Thank you, Dr. Harris, very much for this interesting topic. And actually, I agree with Dr. Hussein very much with his comment, because all guidelines, even when we put guidelines for local guidelines, we mention at the end of guidelines are not meant to replace attending physician decision and treatment of patients, because some patients will have different presentations, will not fit with the guidelines. So whenever you have doubts that these patients even need to add some anti-anaerobes or anti-pneumonia, you can choose and treat the patient, because guidelines are guidelines for general, but they are not replacing the attending physician decision on different patients. So I agree too much with the person.
Yes, subjective decision of physician is important. Dr. Faisal.
Can you use the mic?
Aspiration pneumonia, the only problem is that it happens mainly at the extremes of age in small children. In small children, when they aspirate milk or the fluid contents, it becomes very severe because they go into cyanosis. So it becomes more like an emergency. The other extreme, when they're old, they aspirate. And as you know, there are multiple comorbidities. So they have a baseline health status is very weak. So if we withhold antibiotic for 48 hours, we may not be doing justice in such cases where they have a very low baseline health status, they have comorbidities, heart issues. So a right middle lobe aspiration can be a disaster. However, I'm saying that as you mentioned very clearly, the aspiration pneumonia is not an infective pneumonia. It's actually chemical pneumonitis. It's like the acid burning of the lung tissue rather than an infection. As you know, the acid is a very good antimicrobe. So it's justified in patients who are not having very serious comorbidities. But in elderly patients, I'm a little skeptical on withholding the gram-positive and the anaerobic coverage. Thank you.
Agree with you. But this one, pediatric is not included here in the guideline. Pediatric, they have different set of guideline, and it's their aspiration is slightly different. They are managed.